Welcome back, everyone. Today we are tackling the body's silent drainage network, the lymphatic system. It is often the forgotten system in the shadow of the heart and lungs, but in the clinic it is absolutely front and center, especially when we talk about cancer. Dr. Sarah, are you ready to map this out?
Ready as ever, Dr. Khan. For the boards, students often overcomplicate this, but we can simplify it. At its core, the lymphatic system consists of lymphatic organs like the spleen, thymus, tonsils, and nodes, plus a vast network of vessels that return tissue fluid back to the venous system. It's a one-way street, not a circle.
Exactly. Think of the cardiovascular system like the main water supply to a house, and the lymphatic system as the floor drains and sewage pipes. If those drains get backed up, the whole house floods. I see this all the time with lymphedema. But Sarah, let's get into the high-yield mapping. Where does all this fluid actually go?
This is a favorite for examiners. You have to divide the body into two very unequal parts. The right upper quadrant, that's the right side of the head, neck, right upper limb, and the right side of the thorax above the umbilicus, drains into the right lymphatic duct. Everything else, and I mean everything, the entire lower half of the body and the left upper side, drains into the thoracic duct.
That is a huge clinical point. I always tell my students to visualize that umbilicus as a major border. If you have a patient with a suspicious lump in the groin, you aren't looking at the right lymphatic duct. You're following the trail to the thoracic duct on the left. But Sarah, why does this matter clinically, beyond just memorizing a map?
It matters because of metastasis. Cancer cells are like hitchhikers. They break off from a primary tumor, slip into these highly permeable lymph capillaries, and travel to the nearest lymph node. If you know the drainage pattern, you can predict exactly where a cancer will show up next. For the USMLE, you must know that the thoracic duct eventually empties into the junction of the left internal jugular and left subclavian veins.
It's like the highway to the heart for a rogue cell. I remember a case where a patient had a small, almost invisible lesion on his tongue. He didn't think much of it, but because I knew the lymphatic drainage of the tongue, we were able to find an enlarged, deep cervical node that confirmed the cancer had already begun to move. I remember my mentor, who was essentially the doctor of choice for complex neck dissections, always said, if you don't know the lymphatics, you're just guessing where the fire is going to spread.
That's a great clinical pearl. Let's talk about the nodes themselves. They act as filters, packed with lymphocytes to fight pathogens. When they are fighting, they swell. But there's a difference between an infected node and a metastatic node. Dr. Khan, how do you distinguish them in the exam room?
Great question. Usually a node that's tender, warm, and movable is more likely to be an infection. Your body is actively fighting. But a node that's stony hard, fixed to the surrounding tissue and painless, that makes my clinical alarm go off. That's often the sign of a secondary tumor or metastasis. The cancer cells have not only reached the node, but have started to invade and replace the nodal tissue. Sarah, what about the valves in these vessels? I know the boards love the mechanics.
Yes. Just like veins, lymphatic collecting vessels have valves to ensure one-way flow toward the heart. This gives them a beaded appearance under a microscope. However, unlike the heart, there is no central pump for lymph. It relies on external forces like your muscles contracting or the pressure changes in your chest when you breathe to move the fluid along. This is why patients who are immobile for long periods get puffy or develop edema.
It's all about movement. If the pump, which is actually just the patient moving, stops, the drainage stops. Now, why does this matter clinically when we talk about surgery? We see a lot of post-surgical lymphedema, particularly in breast cancer patients.
Precisely. When a surgeon performs a radical mastectomy and removes the axillary lymph nodes to check for cancer spread, they are essentially removing the drainage pipes for the entire arm. Without those nodes and vessels, the fluid has nowhere to go, leading to massive swelling in the limb. It's a classic board scenario, post-mastectomy patient with a swollen arm. The answer is always impaired lymphatic drainage.
It's a trade-off we have to manage carefully. We also need to mention the exceptions. The book mentions that the CNS, the eyeball, and the internal ear don't have these traditional lymph vessels. Everything else is fair game. And let's not forget the child. Sarah, help the students with the milky lymph found in the gut.
The lacteals. These are specialized lymph capillaries in the small intestine that absorb emulsified fats. The resulting fluid is called chyle, and it's milky white because of the fat content. This chyle travels up the thoracic duct. So, if a patient has a traumatic rupture of the thoracic duct in the chest, you might actually see milky fluid leaking into the pleural cavity. That's called a chylothorax.
A milky lung. That's a visual no student will forget. To wrap this up, why does this matter clinically for the average primary care doc? It's about being a detective. If you find a swollen node in the supraclavicular area, specifically on the left, you have to think about what drains there. Since the thoracic duct carries lymph from the abdomen, a Virchow's node there could be the first sign of a hidden gastric cancer.
Perfect. Let's summarize the high-yield takeaways. 1. The right lymphatic duct handles the right upper quadrant. The thoracic duct handles everything else. 2. Lymph flows one way toward the venous angles in the neck. 3. Cancer spreads through these channels to regional nodes. And 4. Fixed, hard nodes are a major red flag for metastasis.
Great summary, Sarah. Knowledge of these drainage routes isn't just for the exam. It's how we save lives by catching the hitchhiking cancer cells before they reach the main highway. Thanks for tuning in, everyone.